Thank you so much for the organizers for inviting me to Bahrain. It's a very dear place to my place, and it's really a nice opportunity to meet colleagues from medical school and colleagues from the region. Well, thank you again so much for having this session, because in every single endocrine congress we have male hypogonadism, male erectile dysfunction. Everything rotates around males, but then females can have issues too. So the trigger basically for this presentation is basically a couple of months ago I had a couple who came to my clinic because I was introduced as a lead for thyroid cancer, so why would I speak about female sexual dysfunction? So a young couple in their 30s, they came to my clinic, and then I thought it's like diabetes or thyroid issues and stuff, and then there was like a moment of silence. I said, yes, how can I help you now? And then the minute the woman wanted to talk, the husband came on the picture and he said, doctor, we're having a divorce. And so I stepped back. How can I help you? I'm a clinical endocrinologist. I'm not, a psychotherapist or so. He said, my wife is cold. Okay. My wife is not engaging. You know what I mean. Yes, I know what you mean. How can I help you? So he said, I gave her ginseng from Korea. I gave her that supplement, DHES, from Dubai. They sell it over the counter, by the way, in Dubai, for your knowledge. And maybe you can check her hormones. Maybe you can do something about it. Maybe you can give her some testosterone. So from that drive, I thought, yes, maybe I can help. So now as endocrinologists, we can save marriages. This is another target for our goal. So basically, is there a mic here or not a mic, just how to flip the slides? Oh, okay. So in terms of the disclosures, I have nothing to disclose, but I just wanted to alert you that this is a rated R presentation. So if anybody in the audience which is 17 and less, maybe you need to bring your parents. But actually, on the contrary, I think this is a public health concern, and every parent needs to educate their kids around the age of 16, 17 about what can go wrong in a relationship. So I'm going to talk about the female sexual dysfunction, some definitions, some prevalence. We'll talk about risk factors, the effect of diabetes on female sexuality, some management strategies, and I'll review some of the pharmaceutical agents in managing female sexual disorder. And I would really look forward to hear from other colleagues from Italy if you're using any of those modalities. So when I say that there's a female sexual disorder, so I'm referring to something which is recurring, and it is persistent inability to attain or maintain a complete sexual activity without being distressed or being in pain. And that broad definition can be subdivided into hypoactive sexual desire disorder, or sometimes used interchangeably with a sexual arousal disorder. Or sometimes it is female orgasmic disorder. So it's like a cascade of disorders that tackle particular aspect of a woman's sexual cycle. Having said that, it's really important just to familiarize yourselves with the female sexual response cycle, and which starts from a desire, arousal, orgasm, and recovery. So what happens in of course, the desire, just be alert and mindful that there's a clitoral changes, there's an increase in diameter, the uterus becomes a little bit more erect. At the arousal stage, there will be more lubrication and more vaginal mucinous secretion. And at the orgasmic, there is the strong vaginal contracting muscles at the end with the contraction of the anal orifice. And then everything becomes back to normal at the recovery phase. So everything can go wrong in any of these phases. If I wanted to know about what is the size of the problem, so it's actually a sizable problem. So this is one of the large global prevalence surveys that was done and published in 2004. And they've collected data from 28 countries. Out of the, let's say, Middle Eastern countries, there was some data from Turkey, Algeria, Egypt, and Morocco, just to have some feel about that this is something really across the board. And they've looked at the prevalence of sexual dysfunction in women by areas, and have also looked at multiple facets of the sexual dysfunction, whether it's a lack of sexual interest, inability to reach orgasm, or having pain or lubrication difficulties. And they have found that the majority of the problems basically was the lack of sexual interest in women and inability to reach orgasm. And just as a curiosity, I thought, what about our Middle Eastern women? Well, it happened that 43%, the maximum number of lack of interest in sexual activity, were from Middle Eastern women. Looking at the risk factors for female sexual dysfunction, so this is just a review that was published recently, looking at a broad spectrum of countries with some gender or sexual regime, whether it's a male predominance or a mixed male predominance. And you can see that, of course, we can understand that if there is any sexual abuse or rape or anything like that, that can trigger some sexual abnormalities and behavior, a negative behavior in women. But I wanted to focus on that middle portion. So there's the presence of smoking, older age, depression, poor physical health, medical conditions like diabetes or disability, and lacking sexual knowledge and education, which is quite important. Having said that, it is, I mean, look, talking to these, the young couples that I saw a couple of months ago, I took the woman to a separate room, pretending that I'm going to do a scan for the thyroid. And I said, come on, what's going on? Tell me. And she said, she's burst into tears, and she said that I'm awake from 5 a.m. in the morning, preparing breakfast, doing that, cleaning this. I don't have a maid, teaching the kids, bringing the kids back, this and that, ironing, cooking, that's all housework. And what does my husband do? He goes to the work, and then he comes back and eats, watch TV, preferably football, and then he expects me to be Beyonce or Shakira or whatever. So please don't go into that phase yet, please. Hold on. So I thought that it's really important when you educate your youngsters or colleagues or your relatives that it is, I mean, this is a joke, but it's quite true that you need to know what goes in the mind of a male and what goes into the mind of a female. So it's not like there's a mismatch between what are the priorities in a simple life. We're not talking work now, we're talking home and intimacy. And if you want to compare that with the female brain, and actually shoes takes a big chunk of a woman's thinking. And if you want to impress your woman, I would really suggest that you have a high heel shoes. That really works very well normally. Isn't that true? Yeah. So sexual dysfunction in diabetic women. So if we want to just move on to diabetes. So does diabetes make things worse? Actually, data are few, and they lack standardization in methods, and sexual dysfunction in men, actually, yes, it gained more interest because talking in women is considered taboo or complex, and there's no time for it. And there has been some various studies show inconsistent scores for sexual dysfunction indices in women with type 2. But I'll go through some of those results shortly. So what if the first publication about erectile dysfunction in men was actually highlighted in the literature in the 1950s? Women dysfunction in diabetes was published in 1971. And this is one of the first, if not the first, publications that highlighted sexual dysfunction in diabetic female. And that showed that there is a 35.2% diabetic women compared with 6% diabetic women, non-diabetic women that are actually having sexual dysfunction. And he has noticed that through questioning females, 125 females, in the reproductive age group, that there is actually a sigmoid or an S-shaped graph that correlates with the duration of diabetes. But that was in the 70s. And there has been a big gap of silence about diabetes and the female sexuality. Because there was no standardization of a tool to measure female sexual index in females, a tool to actually quantify or how to measure female sexual function until the 2000 when Rosen and group actually came up with this 19-item female sexual function index. It's a self-reported measure, it's a multidimensional, and looks into the 4 stages of the sexual cycle of a female, give them a score, multiplied by a factor. And then if there's anything, sum it up, if the score is less than 26.5, then this is a positive for female sexual dysfunction. And since then, there has been multiple studies using this tool to quantify female sexual dysfunction. And of the major meta-analysis that was described in 2013 and looked into 26 studies, and looking at more than 3,000 females with diabetes, comparing them with non-diabetic women, and they have found that there is an increased 2.2 times sexual dysfunction in type 1 diabetics and almost 2.5 times more in type 2 diabetes. And this was regardless for the duration of diabetes. So when we say duration of diabetes, you immediately think of age, and you immediately think of menopause in women, because those are quite important confounders in any study that needs to be conducted over long term. More recently, another female sexual dysfunction meta-analysis that looks specifically for type 2 diabetes, and there has been the prevalence of sexual dysfunction in women from the age of 18 to 70 in type 2 was around 67%. So it's like twice or 3 times the prevalence of diabetes itself. And I just wanted to highlight one of those studies that was mentioned in that meta-analysis, and that was published in Saudi 2017, because it's not that I'm criticizing Saudi women, it's just that those people have gone miles ahead of us in publishing and talking out about their female sexual disorders in diabetes. So that actual publication, they looked at the prevalence of sexual dysfunction in type 2 and whether it has it has been affected by age, glycemic control, or obesity. And they have found that 88% of Saudi women with type 2 had sexual dysfunction using that actual scoring system. And they've also they found that there's a significant association with increased age, but there was no association with glycemic control. So one would expect that the higher the A1C, the poorer the glycemic control, the more nerves are affected and the worse it is. But that wasn't really consistent across studies. And the good thing about this study is that they've also looked at the distribution of the population according to medications and sexual dysfunction, if there's any correlation. And they have found no association with concomitant medications. And you can see the list. They've looked into calcium channel blockers, beta blockers, statins, diet, oral insulin use, and even the antidepressants. They have found that there has been no correlation with that. Now, if I wanted to look into what particular area of the sexual cycle that is mainly affected by diabetes. So this actually looked at mainly there will be a loss of lubrication and moistness in 70% of the times, and followed by the lack of interest in women with diabetes. Of course, there are so many other things that in a survey you can have a mixed method with the way that you can calculate and get the feedback from women, quantitative and qualitatively. So if I want to just have a little bit of a focus, what would be the pathogenesis of female sexual disorders in diabetes? Of course, the psychological, maybe like 70 to 80% of the problem lies with partnership issues, obesity-related stress, and low self-esteem and depression. But it's also important to know that hyperglycemia per se affects the vaginal infections. It can put the woman more at risk of having lack of lubrication. There is definite and endothelial dysfunction. We know it is in all the vascularity of the body. And there is the decreased bioavailability of nitric oxide with a decreased vaginal blood flow. One would expect that also neuropathy, the alteration of the transduction of the sexual stimuli, and that causes causes the pain that women can actually have. Hormonal changes, we know that insulin and IGF modulates aromatase and the 3-beta-hydroxysteroid dehydrogenase, and that can maintain also the estrogen receptor expression at the hypothalamus, and it has been shown that it plays a major role in the proliferation of vaginal epithelial cells in rat. So if I want to translate this information into the actual female sexual response cycle, and we can see that reduction in vaginal and clitoral blood flow affects definitely the desire as well as the neuropathy. In the arousal or the lubrication, the vascular damage decreases the vaginal blood flow, reduces the lubrication, which can actually cause the dyspareunia, and the actual alteration in the relaxing capacity of the vaginal muscularity and the neuropathy can affect the orgasm. So, recently, there has been a publication about the response cycle and the glycemic control. So this is actually what we wanted to make sure. So if I make HbA1c much better, would the symptoms of that woman improve or not? So this actually, they looked into 182 females above the age of 30 with a duration of not less than 5 years, and without psychiatric illness. And they have looked at a modified score, they've used that, and they've used it in a modified way with a shorter version. And they found that the sexual dysfunction was statistically significant with HbA1c, hypertension, nephropathy, and neuropathy, but it was not associated with the duration of diabetes, BMI, or retinopathy. Again, some studies you will find that yes, it will be a positive correlation with A1C. Other studies will actually deny that. I want to move on to look into the modern anti-diabetic agents and if it has any impact on female sexuality or sexuality in general. So we understand that if we improve, I mean, this is just logical, if I improve the glycemia and I would improve the vascularity and the endothelial function, I would expect that the overall body and the well-being of a man or woman will be improved. And it has been seen that the use of the DPPI and the SGLT2 inhibitors will actually improve the endothelial progenitor cells for the more availability of nitric oxide and the positive impact on the pituitary adenylate cyclase activating polypeptide, resulting in vasorelaxation and anti-atherogenic effects, which improves the endothelial function and ultimately improves erectile and overall sexual functions. And the GLP-1 receptor agonists, with its impact on body weight and glycemic control, have also been positively impacting the sexual functions of both men and women. However, most of the studies were conducted on men or rats, but not in women, as if we're like a different species. So studies evaluating the effect of the new anti-diabetic, you can see that it has been, we have used, and like you can see there's the majority of DPPI used in mice, GLP-1 receptor agonists in type 2 diabetes, sometimes with the obese, with or without oral hypoglycemic agents. And you can see that basically some have improved, but as I said, it's mainly in men and not in women. So, شو الحل? So what to do? What's the solution now? I like the publication that was published by the Canadian Urology Association that looked into, again, the basic principles, history taking, physical examination, and then do some investigations. So history presenting illness, sexual history, use of oral contraceptive pills, some physical examination in general, and vaginal pH for atrophic vaginitis can be used. You understand that these women may not come to you as an endocrinologist. If you are a family physician, they will come to you, and if you are a psychotherapist, they will come to you. So just be mindful of what are the things that can be investigated for. Obviously, if the patient has hyperprolactinemia, thyroid dysfunction, or any of the hypogonadal or pituitary dysfunction can actually lead to sexual dysfunction. Medications, it's quite important to know if the woman is on antidepressants or SSRI or using tamoxifen or any of those kinds, because they can impact women's sexuality. The management of female sexual dysfunction, of course, it depends on what phase of the sexual cycle is impacted, whether the pain, is it the desire, is it the arousal, or the orgasm. So basically, a good history needs to be obtained before you can jump into what modality that you can start. But in general, if I just jump over the psychotherapy part and the trying to elicit more information from the woman, keep in mind that those medications have been used, but not all of them are actually licensed. So if we took at the first one, the flibanserin and the premalonatide, those are FDA approved for premenopausal women, but they're not widely used. And you can see that the first one is orally taken, the last one is an injection to be taken just before intercourse, and it's not devoid of side effects. Bupropion has been used also for smoking cessation, but it also has been used even in our clinic in Abu Dhabi with variable results. Testosterone I have to say that testosterone is only approved for female sexual dysfunction in Australia, but it hasn't been approved elsewhere at all, because of course the side effects, the anticipated side effects. So that person who came to me and he said that I gave my wife the Korean ginseng or whatever, and he wanted to give also the testosterone, and he wanted to give Viagra. So looking into the role of phosphoesterase 5 inhibitors, should we use them? Do they actually work for women? So studies have been conducted for premenopausal, postmenopausal, or sometimes mixed pre- and postmenopausal, and the results have been variable. Actually, the majority of the results were positive, especially in those who are having like a spinal cord injury. So this is just the result of the meta-analysis. So they have like a little bit of a benefit in simple sexual dysfunction. Spinal cord injury was useful, and also in those who are using who are having antidepressant associated sexual dysfunction. But in general, the significant increase in side effects like the headache, the flushing, and the change in vision put us off using the sildenafil and the other products. And now, of course, FDA does not approve the use of Viagra or sildenafil in women. However, I have read reports of the Cialis 5 milligrams that might have a positive impact. I don't have an experience, but maybe we can just list if you have some feedback from our colleagues from abroad. Now I'll get to the final point, the role of testosterone in female. We know that a woman has an estrogen and has a testosterone. And the testosterone in women, 25% comes from the ovaries, 25% comes from the adrenal, and the rest comes from the conversion from the androstenedione. And it's important to know that the testosterone doesn't stay in that state. Of course, it gets with the aromatase to estradiol, and it gets converted to the more active form, the 5-alpha-DHT. But it's not really clear whether the testosterone will positively impact the sexual desire in women through direct stimulation of the androgen receptors, which are really abundant in the perineum of women, or through indirect effect, through its effect and conversion to estradiol. So basically, you just need to be mindful that we need to have both the estrogen and the testosterone, because both of them need to actually regulate the receptors, the androgen receptors in the perineum. Particularly the testosterone receptors, the androgen receptors are detected in vagina, clitoris, labia, and the pelvic floor. Testosterone stimulates vaginal nerve densities and maintain the vascular smooth muscles, and are responsible for the mucinification of vaginal epithelium, whereas the proliferation of vaginal epithelium and the vascular transduction is maintained by the presence of estrogen. So should we use estrogen in assessment? Should we test for testosterone in women? So actually, until now, there is no absolute level of any androgen that's signal for female sexual dysfunction. There is no threshold below which the female has sexual dysfunction, because it's a multifaceted, and the only tool to test sexual dysfunction at the moment is history taking and using the scoring system. Androgen effects of testosterone actually varies because of the variation in the activity of the 5-alpha reductase and the aromatase, and therefore we can't really rely on its bioavailability alone. And there is a loose correlation between the testosterone concentration and its beneficial effects to women. Sometimes a lot of testosterone will put her off and not the other way around. In Australia, they have used the transdermal testosterone. There hasn't been an approved female formulation, but they have used it with some success. And the compounded testosterone was not recommended by the International Society of Sexual Medicine, recently published. More recently, there has been some reports from kisspeptin use, which is a neuropeptide from the hypothalamus, and it is, regulates the onset of puberty in both sexes, and it also stimulates the hypothalamic gonadal ovarian axis. And they have found that in this randomized controlled trials, over a small number of premenopausal women with hypoactive sexual desire, that it actually works, and works in terms of a positive functional neuroimaging can be seen in the psychometric analysis and hormonal analysis. I think the take-home messages from this, as I said, this is a public health issue, that female sexual dysfunction is common. It can be up to 80%, that is often neglected. Diabetes affects all stages of the sexual cycle in females, especially the desire and arousal. Factors related to both psychological and organic causes have been confirmed, and there has been no consistent correlation between female sexual dysfunction and glycemic control. However, the association was there and is significant with the presence of neuropathy. With the management strategies, we really need to rely on proper psychosocial investigations, history eliciting, and possibly potential use of testosterone. With that, I come to my conclusion, and I'll be happy to answer some questions. Thank you very much for your attention.